First of all, on behalf of Scientific Icon 2022, I welcome all the audience, respected seniors, and guest speakers. We have a mixed flavor of gastroenterology and hepatology topics today. This course is for postgraduate trainees, especially for the internal medicine, family medicine, and GI trainees. We'll be discussing very basic and simple things which we face in day-to-day practice in our outpatient clinics and ward patients. And we'll be having question answer session at the end of session after talks. And our first speaker is Dr. Mohammed Saleh. He is working as consultant gastroenterologist and transplant hepatologist, currently working at Shifa International Hospital, Islamabad, and is chief of hepatology, transplant hepatology in Islamabad. And he had done his fellowship from Pittsburgh University of Medical Sciences in USA, and he is also vice president of PSSLD. And his talk is approach to patients with abnormal LFTs. So, Dr. Mohammed Saleh, over to you. Thank you.
Thank you, Dr. Hamid. Am I loud and clear?
Yes, sir.
Okay. So I'll be sharing my screen with you.
Sure, sure. Thank you.
Mhm.
Sir, please share entire screen.
Okay. Now you can see my slides.
Yes, we can see your slides.
Okay. Bismillahir Rahman Rahim and Assalamu Alaikum. I'm really thankful to the organizers of the 6th Biennial Indus Conference 2022 for giving me the opportunity to talk to you on a very basics and um, simpler but essential liver function test. So we will be discussing approach to patients with abnormal liver functions tests. So I have no disclosure regarding this presentation, and the outline of the talk will be pretty simple, as you mentioned in your talk, your initial nice introduction. That why this is this talk important, and what are liver function tests, or in fact liver dysfunctions or diseases, and what are LFTs, and how to interpret and proceed. So, why is this talk important? Because we routinely ask for few basic tests, which we usually call them LFTs, which are ALT, AST, total and differential bilirubin, along with gamma GT and alkaline phosphatase. The prevalence of abnormal LFTs is pretty high, I would say so. If you screen for or you look at anybody's chemistry, if you ask for LFTs generally, so there is a chance that in 10 to 20% that at least you may find one or more abnormalities in LFTs. However, majority of these abnormalities will be transient and may not be suggestive of a disease. And in reality, only less than half of these will translate into specific or significant liver diseases. But we also know that this may give us a false sense of reassurance and leading to a late diagnosis or a misdiagnosis, and hence it is the responsibility of the ordering physician, be it a primary care physician, general practitioner, or a medical specialist or hepatologist or gastroenterologist, to find the needles in the haystack So on one hand, we are saying that these abnormalities, transient abnormalities, is pretty common. On other hand, we are saying that we may be missing or late diagnosis these patients. So anytime you find an abnormal liver function test, please do not discharge them from your service until and unless you have documented that that abnormality was transient or you have find a cause for that transient abnormality, be it a small sore throat or a use of some antibiotics or any other exposure. And to complicate the matter further, there is a twist to the story that 1 in 5 patients, even with advanced liver disease like cirrhosis, may have normal LFTs. So, while on one hand, LFTs suggests that there is some liver inflammations or liver pathology may be there, on the other hand, the normal LFTs may not rule out significant liver diseases. So, in this context, we should be listening to the rest of the talk, and this brings us that what are liver functions or liver function tests? Interestingly, when we refer to the liver functions, these are not the routine functions, these are the non-invasive methods of screening of liver dysfunctions, or on the other hand, liver functions. And these would help in identifying general types of disorders. That is, whether it's hepatic disorder, cholestatic, prehepatic, or a mixed disorder, or is it a acute uh, disorder or a chronic disorder. And these also helps us in to categorize these disorders or diseases or dysfunctions, that how severe they are, and will also allow at times guide us or allow us to predict the outcome. Like if you have got an acute liver failure status and the bilirubin is high and so is the INR, and the patient is having in the clinical context hepatic encephalopathy, so this is an acute liver failure, and probably without a transplantation that patient may not recover. The liver function test, broadly classified as, these are tests to detect hepatic injury, whether it is mild or severe, or acute or chronic, and sometimes they also help us to categorize these injuries into hepatocellular or hepatitic, mixed variety, or cholestatic. So the liver function test broadly categorizes uh, the diseases or dysfunctions into some categories and point us or direct us that how we should proceed further. The classifications are LFTs. We can classify these liver function tests as a marker of liver dysfunctions, which are mainly the prothrombin time, the bilirubin, and albumin. The prothrombin time is very important as it has got us a relatively less or half life, while albumin has got about 20 days of half life. So the bilirubin is high in specifically the total and conjugated and the liver dysfunctions. Albumin may be low in variety of other conditions, including malnutrition or other chronic diseases. However, in the clinical context, if the albumin is low, then hepatocellular dysfunction is going on. And of course, prothrombin time is with a shorter half life predict tells us that there is severe liver dysfunction is going on, specifically if there is no vitamin K deficiency. Then there are markers of hepatocellular injury, which are mainly, there are so many others, but we rely on AST and ALT. We also call them as GOT and as GPT, and these helps us. And if they are high, then we say that there is hepatic or hepatocellular injury is going on. While AST may be high in some other condition as well because it's present extrahepatic as well, like in muscles and other organs. Then there are markers of cholestasis, more so alkaline phosphatase, the gamma GT, and the conjugated and direct bilirubin. So when they are deranged significantly, then we say that there is some cholestasis is present. However, they may be high in hepatic cellular damage as well. So it's not that simple, but broadly, these three types of categorization can be made. Now we will just concentrate on individual liver tests, and we will start with the bilirubin. We know that bilirubin is basically it's coming from the heme or the hemoglobin degradations, and that is metabolized into bilirubin. This can be the type of jaundice or high bilirubin can be of three varieties. There's a prehepatic, hepatocellular, and the posthepatic. Now, the prehepatic can be there if there is hemolysis going on, if there is dyserythropoiesis or hemoglobinopathies, while in the absence of those, it may still be high in other condition when there is a liver dysfunction, but like a Gilbert syndrome or Crigler-Najjar syndrome. While the Gilbert syndrome is compatible with the normal life, sometimes in Crigler-Najjar syndrome, we may even need a liver transplantation. While the hepatocellular in hepatocellular condition, usually it is the direct one or the mixed variety of the both direct and indirect bilirubin may be high, and these hepatocellular or hepatitic type of injury bilirubin can go up due to any reason, including various hepatitis and other conditions. The post-hepatic one is the one in which cholestasis is there, more so the extrahepatic cholestasis, be it due to the gallstones or the strictures of the bile duct due to benign or malignant stricture like the carcinoma of the pancreas or cholangiocarcinoma. In those conditions, the alkaline phosphatase and gamma GT are also pretty high. While the direct bilirubin can also be high in severe cholestasis, which may be the result of hepatocellular injury. The serum albumin, we know this is the most abundant protein synthesized by the liver with a longish half-life of 20 days. So in severe acute liver injury, this may not be low. While this may be low in other, if the patient has got multiple comorbids or malnutrition, or the patient is suffering from any chronic diseases, then it may still be low. Does not necessarily points to that, but if in the clinical context, if this is low in liver diseases, we know that there is significant liver damage has occurred, and the synthesis depends on the extent of functioning liver mass. Its level decreases in all chronic liver diseases, so it's not like specific for one disease or other disease. However, this is the reflection of the synthetic liver functions. If it is low, and in the clinical context, if there are no other causes, then one can say that the liver damage has progressed, or there has been acute or chronic liver failure is setting in. The serum globulins, and more so the gamma globulins, they are important to us and they constitute immunoglobulins, while the polyclonal globulinemia is usually present in all chronic diseases, more so in chronic hepatitis or cirrhosis. But the individual gamma globulins like immunoglobulins IgG more so is high in autoimmune hepatitis, while IgM is raised in primary biliary cholangitis, and IgA may be high in alcohol related liver diseases. So they also helps us in that, and sometimes the AG ratio is reversed when the globulin are high and the albumin goes down, so the AG ratio is more than is reversed. The most important of the liver function is the prothrombin time. If we know that this is vitamin K dependent, and if there is no vitamin K deficiency, and if this is high, then there has been significant damage to the liver parenchyma. We also know that the liver has got a great capacity, and when the prothrombin gets higher, the INR is prolonged, then we know that the liver has lost more than 80% of its reserves or the capacity. One thing which I would like to clarify here is that if there is a hepatocellular damage going on and the prothrombin time is high, and if you give vitamin K, it does not affect the prothrombin time in liver diseases. So by giving a vitamin K, you do not do any harm, and if it gets corrected, indirectly this tells you that okay, there may be a liver damage is going on, but this the liver has got some capacity because there was an additional vitamin K deficiency. So it can still be given, and if specifically if the patient is has got prolonged illness, has been exposed to multiple antibiotics, it's always better to give or to replace vitamin K. It has got a shorter half life, and it helps us uh, as it is only synthesized in the liver, so it's a marker of severe liver dysfunction, and this helps us in to prognosticate these patients. And this prothrombin time is part of the all major severity grading system, be it model for the end stage liver disease or the child Pew scoring system. Even it is there in the when we are listing these patients for liver transplantation in acute liver failure, like in the most important one, the King's College criteria. This brings us to the normal or routinely measurable enzyme, which is the AST, aspartate aminotransferase. We also call sometimes it's SGOT, and this is a marker of hepatocellular damage. It is present both in the cytosol as well as in the mitochondria. It has got a relatively shorter half life than the comparatively shorter half life than the ALT. However, the mitochondrial AST has got a longish half life. So this can be high in any hepatocellular damage, be it viral or otherwise, but it's more so higher in when there is mitochondrial damage, like drugs and toxin exposure, and more so in ischemia, and specifically in alcohol liver disease, and the ratio is usually reversed. It's also high in any sort of hepatitis, more so in cirrhosis, and when in the clinical context the AST to ALT ratio reverses, then we say that this there may be significant fibrosis going on. The alanine aminotransferase, or the SGPT or ALT, is more liver specific than AST, because AST is also present in the muscles or the brain and other tissues, while the ALT is more related to the liver, and it has got a relatively longer half life of 47 hours. It's high or very high when there is an acute hepatitis, while mild to moderate elevation will be there in the chronic hepatitis. Normal or mild elevations are found in the presence of cirrhosis. So if ALT is normal, it does not necessarily mean that there is no cirrhosis, because now the through these CMEs like the one we are uh, currently or just now attending, has educated our masses, or more so our doctors. But previously, while the ALT people would say when it is normal, then they would say there is nothing is going on in the liver and your liver is okay. It's not the case. It's not that simple, and it's not the case, because there is also another debate that what is normal. Like somebody may have an ALT of 10, and even when it increased 300% or three times, it goes to 30, and you have got still a normal, the ALT in the normal range. So it's basically when ALT is high, it helps you, while when ALT is normal, then it may not help you in ruling out diseases. So if the clinical condition is there, then you will take the help of other tests, not only discharging the patient on the basis of a normal ALT that there is no liver disease. Alkaline phosphatase, it's present in so many things, but mainly in the bones and in the liver. In the liver, it is present on hepatocyte membrane, and it's a marker of cholestasis obstruction or an infiltration. And it's non-specific to the liver because it may be high in the growing bones, or if, after the fracture or so, because it's produced by the bone osteoblast. But in those cases, the rest of the enzymes will be okay, and more so the gamma GT will be normal. The high level are observed more so in the extrahepatic obstruction to the bile ducts, and it may be high in infiltrative diseases, including the intrahepatic cholestasis. Mild to moderate elevations may be seen in any hepatitis or alcoholic hepatitis, or even when there's the infiltrative processes of the liver is there. So in cirrhotics, when it starts getting higher and higher, one may be thinking of or one should must be thinking of hepatocellular carcinoma setting in. The gamma GT, or the gamma glutamyl transferase enzyme, is more sensitive but least specific. And if it is high and alkaline phosphatase is high, then we say that the alkaline phosphatase is coming from the liver, uh, is used for the glutathione synthesis, and gamma GT is increased in alcoholics despite the normal function test. It's a very sensitive to detecting alcohol abuse if there are no other reasons for the high gamma GT, but it may be high in any other diseases, any other hepatitis, steatohepatitis, or even after the use of drugs. Now, this brings us to, after this small, simpler background, this brings us that how do we approach to abnormal LFTs? Everything starts in the clinical context, and one should take a very good history and do a proper clinical examination. And the history and examinations should be more focusing on the whole of the, like it should be a holistic approach. And our history must include the socioeconomic status, the patient's drug history, allergies, and all those are important, and more so the contact histories or the risk factors for viral hepatitis or other diseases. So, after this, we can categorize the abnormalities into either the patients are having hepatitic type of liver injury, or it is cholestatic type of liver injury, a mixed variety, or there is only an isolated high bilirubin, or there is a severe synthetic liver failure in the form of pretty high INR, more jaundice, or if we suspect that there is a weight loss and some malignancy is going on. So this is, we should be categorizing these patients into these broad categories. I'll not be discussing the alcohol related risk or alcoholic related liver disease here, but take proper history do, from any patients. Your question should be polite, but a polite inquiry is always mandatory. I have at least two female patients in my follow up who have cirrhosis due to alcohol. So it's not like you ask, you look at Muhammad Saleh without a beard, you ask question, and with a beard you don't. No, polite inquiry is always important. So do that, please. Now we will start on the left hand side with the hepatitic liver type of injury or hepatocellular damage, and one should be looking at these enzymes where they are mild to moderate, there is a mild to moderate rise or a very high rise, and also think whether it's an acute event or it's a chronic event. So it's not only ALT or AST, you should be looking at the whole of the liver function test along with full blood count, and you ask for an ultrasound. Along with that, if these are high in the clinical context, you look for the viral etiology, and then further testing are warranted, which are metabolic and autoimmune. I'm not saying that you may be asking for all these tests upfront because our scenario is a little different than the West, but ideally you need all these tests. And you should be looking at your ultrasound, the viral serology, and the autoimmune panel. So you may be doing it in steps, or you may be doing it upfront, and this will help you. And I said at the start of this slide that a history and the clinical examination is important. You should be knowing that your patient is diabetic or having a metabolic syndrome or not, your liver is showing steatosis or not. And on the basis of that, if you are you will be categorizing these either it to a viral hepatitis or an autoimmune or Wilson or other metabolic conditions, and or NAFL NASH, which is a non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. Of course, we have by by taking a good history, we should have ruled out alcohol steatohepatitis. Also, be mindful of one thing, that it does not necessarily requires obesity for the fatty liver or the non-alcoholic fatty liver disease, because no-full or non-obese fatty liver is pretty common in our part of the world, because we are mainly sarcopenic, and this is a relative ratio of the mass to fats. So we are sarcopenic, or we have got less mass, muscle mass, while our BMI may be normal or just high. So if you have diagnosed NAFLD, then of course there is a separate algorithm, and these patients should be managed with the help of endocrinologist. Now, all patients who have got fatty liver disease or abnormal LFTs or NASH should be screened for metabolic syndromes. And I also should be reminding you one thing, that all diabetics or metabolic syndrome patients should be screened for fatty liver disease. Now, if your all the etiology are normal, the ultrasound is normal. Sorry, if I repeat, if your all etiology have been ruled out the serological by serological testing, and the ultrasound is normal, and the LTST remains abnormal, then further diagnostic tests are required, which are also inclusive of the liver biopsy. This brings us to the synthetic failures, in which when there is a patient has got jaundice, low albumin, prolonged INR, or if there is a clinical suspicion of malignancy like marked cholestasis, weight loss is there, so urgent imaging and further imaging in the form of MRI or MRCP or CT scan is warranted, but please refer these patients immediately to specialist care. In we may have another scenario when only bilirubin is high, and more so when the rest of the functions are normal, there is no hemolysis going on, and it's an indirect or unconjugated hyperbilirubinemia. So the rest of the things that you have ruled out hemolysis, you have ruled out hemoglobinopathies, and only indirect hyperbilirubinemia is there. So usual and ultrasound or other imagings are normal, then this category may be having Gilbert syndrome, or in the clinical context may even have Crigler-Najjar, but more so the Gilbert syndrome is more common. uh, and usually the bilirubin is mildly high, like 3 to 5. Usually it will be in the single digit range, not more than 10. But it's always nice for a general practitioner to evaluate these patients at least once from a medical specialist or a gastroenterologist, hepatologist. Now we move on to the cholestatic part of our liver dysfunctions, where alkaline phosphatase and gamma GT, with or without the rise in the bilirubin, and more so the direct bilirubin, are there. So when you see these, do an ultrasound where there is extrahepatic cholestasis, or the bile ducts are dilated or they are not dilated. If there is an abnormal ultrasound which will show you that the bile ducts are dilated, so then you required an MRI or MRCP, or with or without the dynamic or quad phase or a triphasic CT scan of the liver. And this will help you in the diagnosis along with other appropriate tests, be it like CA19-9 for carcinoma presence or otherwise. One more thing is that if you have got cholestasis but your ultrasound is normal, and the other etiology like the autoimmune cholangitis, autoimmune diseases like primary biliary cholangitis or the primary sclerosing cholangitis, the extended autoimmune liver profile is negative for that, and the enzyme still remains high, and you have and they persist high, then further uh, workup is mandatory and should be done, and needs the help of a gastroenterologist, hepatologist, and the workup will also include doing a liver biopsy. Now, that's how you proceed to the abnormal liver function. But at the end, I will point one important things. Uh, uh, Always think of a drug-induced liver injury, because in our routines we get about 10% of our consults are related to the drug-related liver injuries. Do not forget the drugs, and you should be taking very good history. And your history should also include herbal, alternative medicines, homeopathic medicines, Unani medicines, and all these drugs, and you should be knowing that drug related injury, liver injuries, are not uncommon, and about 10% of our routine hepatology consults on the floor are due to the drug induced liver injury. So do not forget, take a very good history and stop the offending agent, and you may not need extensive workup on these patients at all. uh, I'm not saying that you should always be thinking that this is the coamoxiclav which is damaging the liver, but you should not be missing on these drugs which may cause a liver injury. Currently, in in the era of this pandemic, the coronavirus should be thought of, because it may present only with the liver derangements. And we have seen patients with the liver derangements only, that there are mild symptoms or no symptoms, and the liver enzymes are deranged. So, should be thinking of the coronavirus as well. Also, the medication used for the various things, be it macrolide like azithromycin or remdesivir and so many others, could also leads to drug-induced liver injury. So should never ever forget about this important pandemic which is going on directly or indirectly through the liver. So with that, I'll thank you all for your kind listening. I hope I made this simpler yet essential topic simpler to understand. Thank you. I'll be online and will be waiting for your comments and questions, if any. Thank you.
Thank you, Dr. Mohammed Salih, for such a wonderful and informative talk on such a common topic. And our next speaker is Professor Dr. Javed Farooqi. He is Professor of Medicine, Gastroenterology, Hepatology, working as consultant gastroenterologist and hepatologist at Lifecare Hospital and Research Institute, Hyderabad, Peshawar. And he is ex-head of Department of Medical D Unit, Government Lady Reading Hospital, Khyber Medical University, Peshawar. And he is also ex-president of Pakistan Society of Hepatology. And currently he is CEO of Al Hayat Clinical and Research Center, Peshawar. And he will be talking about refractory gastroesophageal reflux disease. What are our options? To you, Professor Saab. Thank you.
Uh, Thank you, Dr. Hamid, for your kind introduction. And thanks to the organizers for giving me the opportunity to share my thoughts uh, on the very important issue, that's the uh, Gerd. Let me share my slides with you.
Sir, share your entire screen, please.
Yeah, I do that. Am I visible?
You are visible, but can you share your entire screen, please, sir?
Okay. Share entire screen. Share. I think now it will be okay. Is it okay now?
Not yet, sir. Not yet, sir.
Yeah, I'm. This is the share. Share screen. Share screen.
Sir, entire. Click on entire share screen.
Okay, this is the. And now this is the. I think we should.
What?
Because here what I do. Yeah. Let me see. Share screen. This is the entire share screen. And now I'm pressing the share. Are you not seeing my slides?
Sir, not yet, sir. Sir, go in sharing option and click on entire
Yeah,
share
yeah.
screen.
I'm saying this is the share screen, and this is the entire screen. And now I have gone into entire screen, and now I am clicking the share. I don't know. I did try before this presentation, and that worked. I don't know why it's not working now. It did work.
Sir, please do
Yeah,
it
it did
again, sir.
work. Yeah, I did share with me where I mean before the and it was working. I don't know why. This is the entire screen, and now I am sharing the entire screen. I don't know. Well, you can run slides from your and I can read them out, no issue. But I don't know why it's not coming. You are in the show. And still not my slides are not visible?
Sir, not yet, sir.
I don't know. See, I don't know. Here it comes, share screen, and now the entire screen, and entire screen share. Here it comes, Chrome has lost permission to capture your screen. I don't know why it's that way.
We'll get back to you after it resolves.
Yeah, yeah, sure, sure.
Wait for a while, sir.
Please change the battery.
Sir, we are sharing your slides. We're using slide share with you.
Okay, thank you. Okay, thank you very much. Am I audible to all? Hello, can you hear me?
Loud and clear, sir.
Can you hear me, please?
Yes, sir. We can hear you loud and clear, sir.
Okay, thank you very much. Well, sorry for this technical hitch. This happens at times, and really, then there is no way out. Well, I'll just start my presentation. Next slide, please. Well, the topic given to me is the refractory GERD. What are our options? Next, please. The outline of my talk is the refractory, and when I use the word refractory, we should be knowing what's refractory GERD and why the GERD becomes refractory, and we should be able to know and to think how to proceed in this case. Next, please. So to get these answers, we must be knowing some sorts of basic knowledge about what is the GERD, what converts gastroesophageal reflux into gastroesophageal reflux disease, and when we should suspect that the patient is having GERD, and then when to treat as GERD, we should be sure that this is GERD, and how to treat GERD. When we have these answers with us, then it enables us to go for the options of treating the refractory GERD. Next, please. I'll introduce a topic that we know that the GERD remains the most common disease seen by the gastroenterologists, primary care physicians, and surgeons. This is one of the most common diseases. Our understanding over the year has been evolved and enhanced regarding the presentations of GERD, the enhancements in the diagnostic testing and approach to patients' managements. We do know that the clinically important advances in surgical and endoscopic therapy for GERD have emerged as well. What is GERD? We all know that the gastroesophageal reflux is a normal phenomenon, and we define this gastroesophageal reflux in two terms, the two aspects. One is the frequency, that at what rate in normal person this gastroesophageal reflux is happening, and second, the quantity and quality of the refluxate, the material which comes from the stomach into the esophagus, what is its quantity and what's its quality, whether this is acidic, mild acidic, strong acidic, or non-acidic. Gastroesophageal reflux disease is the condition when this normal gastroesophageal reflux results into the symptoms and or complications. And objectively, we define the gastroesophageal reflux disease as the presence of characteristic mucosal injury, which is seen at endoscopy, and or abnormal esophageal acid exposure, which is demonstrated on the reflex monitoring study. What converts the normal gastroesophageal reflux into GERD? And this is important when we come across a refractory GERD, which there are different hypotheses, there are different mechanisms. The most common mechanism is the poorly functioning gastroesophageal junction, which is the normal anti-reflux barrier, and it is composed of the lower esophageal sphincter and the crural diaphragm. The second mechanism is the impaired esophageal clearance, that whatever comes up from the stomach into the esophagus, the esophageal ciliary mechanisms or defense mechanisms are clearing mechanisms, they are faulty, they are not working properly. The third mechanism, if there is salivary production decrease, again it will lead to the delayed clearing of the refluxate from the stomach into the esophagus, and may result in the gastroesophageal reflux disease. Another is then there is alteration in the esophageal mucosal integrity. The frequency of the refluxates of no, reflux is normal, and the quantity is okay, but the mucosal integrity is not there, so the mucosa gets hurt. And the last mechanism is the delayed gastric emptying. When the stomach is not emptying in time, improperly, that stuff comes up when the patient lies down or there's other manure, so it can lead to the gastroesophageal reflux. So when we should suspect that the patient has got gastroesophageal reflux disease, of course, the symptomatology brings the patient to you, and you hear the patients, and then you decide. The most common symptom is the heartburn, and we all know this is the substernal burning sensation which arises from the epigastrium up towards the neck. The next common symptom of the GERD is the regurgitation, which is the effortless return of gastric contents upward towards the mouth, and often it is accompanied by an acid or bitter taste. So there is some sort of difference between these two symptoms. And the chest pain is the third most common symptom of the GERD. We should be clear that the symptoms of GERD are non-specific and may overlap or be confused with those of other disorders like rumination, achalasia, eosinophilic esophagitis, reflux hypersensitivity, functional disease, and even cardiac or pulmonary diseases and paraesophageal hernia. So when these three symptoms, heartburn, regurgitation, chest pain, are there, we do think the patient is having GERD. Next, please. There may be some extraesophageal manifestations as well, and the patient may present only with these manifestations. And what are these? We know this is the sinusitis, pharyngitis, dental erosions, laryngitis, chronic cough, asthma, and even patients have presented with long-standing GERD as pulmonary fibrosis. And we know that these manifestations are challenging for patients and physicians because although they may result from GERD, they may also be due to so many other causes. So really, that brings a diagnostic dilemma for the doctors as well. Next, please. So there is no when to treat as GERD. It means how you will diagnose. There is no gold standard for the diagnosis of GERD. The diagnosis is based on combination of symptom presentation, the symptoms I just elaborated, response to therapeutic intervention. When you give the therapy and the patient responds, you think, yes, this is the GERD. And in case of lack of response and or poor response to the treatment, then endoscopic evaluation of esophageal mucosa is warranted. And even if the endoscopy is normal, then you go for the reflex monitoring. So in the disorder, first the symptoms, then the therapeutic response, then the endoscopy, and then the reflex monitoring. How to treat GERD? You diagnose a GERD. How to treat? There's a multifaceted approach, and it takes into account the symptom presentation, what symptom the patient has come to you, and when there was no therapeutic response, what were the endoscopic findings, and is there any likely physiological abnormalities like diabetic patients with delayed gastric emptying and so other things like scleroderma. So management decisions may differ depending upon the hiatus hernia type and size, the presence of erosive esophagitis and or Barrett esophagus, BMI, and accompanying physiological abnormalities like gastroparesis or ineffective motility with absence or contractile reserve. The treatment depends on these factors. We all know the mainstay of the treatment or the essential component of the treatment is the lifestyle modification in terms of the diet modifications, the content of the diet, the timing of the diet, the body positioning with meals are taken and while sleeping, the weight management, alcohol stopping and the smoking stopping. And beyond that, or in addition to that, different drugs, antacids, sucralfate, histamine, potassium competitive acid blockers, prokinetics, even baclofen have been tried, but the mainstay of the therapy is the proton pump inhibitors. Next, please. Next, please. Well, regarding the PPI therapy, the up to 40% of patients treated with PPI, they report persistent symptoms. So, out of 10, 4 patients will not be having a proper relief from the heartburn and regurgitation, and it will have the negative effects on the quality of life. The symptoms of GERD respond variably to PPIs. This is very, very important, and we should not forget this. For example, the heartburn responds better to PPI than regurgitation or extraesophageal symptoms. This is another point we should be not forgetting. And last point is that the severe reflux, if it is the LA grade C or D, it responds only to PPI. If you diagnose the patient with GERD, you give the other therapies not responding, you give the PPIs and they responded, probably the patient has got severe reflux esophagitis. But point is that when you stop PPI, the symptoms returns quickly. Because what we do when we diagnose a patient with GERD, we give them PPI for 4 weeks, 6 weeks, 8 weeks, and when there is response, we stop that. But after stopping, if the symptoms recur, probably it is the advanced reflex esophagitis. So, what is refractory GERD? By definition, it's the persistent heartburn and or regurgitation despite 8 to 12 weeks of double dose PPI. Initially, we gave the patient single dose or OD dose. There was no response. You doubled the dose. Again, no response. Then you say, well, my patient may be having refractory GERD. Patients with suspected GERD, there are two groups of such patients, refractory GERD. One is that patients with suspected GERD, where you just listen to the symptoms and thought this is GERD, who have been empirically treated with PPI twice, typically once daily, and then I said then we increase to twice daily, yet remain symptomatic. This is one group of patient. Second group of patient is that they have got confirmed GERD either by the endoscopy or by the reflex testing, and you confirm this is the GERD, and you started the patient on PPI, the double dose, for 8 to 12 weeks, no response, suboptimal response. Now you say this is refractory GERD. Next, please. Why? One, please. One slide, please. Yeah. Why GERD becomes refractory? This is very, very important because unless you think about these underlying pathologies, you cannot plan the options available for the refractory GERD. What are these? Despite PPI therapy, there is one chance there may be abnormal acid reflux which persists and is causing the symptoms. So one is it may be abnormal acid reflux. Second possibility is there is reflex hypersensitivity, and it's a condition in which PPIs have normalized esophageal acid exposure, but physiologic reflux episodes, which may be acidic or non-acidic, nevertheless are strongly associated with the symptom. Third possibility is that symptoms are not due to GERD. We shouldn't forget the symptoms may not be due to GERD, but these are caused by esophageal disorders like eosinophilic esophagitis or achalasia. So even these two conditions, esophageal disorders, not the GERD, they may be giving the presentation like refractory GERD. Another possibility is that symptoms are not due to GERD but are caused by non-esophageal disorders. For example, gastroparesis, rumination, and heart disease. So this is another way how the patient can present as refractory GERD. And last but not the least is the symptoms may be just functional, not caused by GERD, not by any identifiable histopathologic motility or structure abnormalities. So it may be just a functional GI disorder. So how to proceed if a patient, you think the patient, my patient is having the refractory GERD, the most important is the history and physical examination. Evaluation of the refractory GERD should begin with a careful history and physical examination. If no obvious non-esophageal disorders are present, then optimization of PPI therapy is recommended. Remember, this is critical for managing patients with persistent GERD symptoms, regardless of whether the patient has been empirically treated or carries an objective diagnosis of GERD. It's a very cost-effective approach that you optimize the PPI therapy. Next, please. So what do I mean by the optimization of PPI therapy? Next, please. By optimization of PPI therapy, what I mean, it is the, as I said, the first step in the management of refractory GERD. It includes two aspects. One is verifying the compliance, that the patient is really taking drugs regularly, and second is confirming that the PPI is taken on empty stomach if this is the OD dose 30 to 60 minutes before the first meal of the day, and if this is the BD dose again before the first and dinner meal twice daily. So this is very, very important that you optimize the patient's PPI therapy regardless of the dose. A small but clinically significant number of patients will definitely have symptomatic improvement with this very simple, cost effective intervention. That please. Next, please. So, you did took the history, you excluded the other causes, and you optimize the PPI therapy. Still, the patient not responding. How to go about? You do the endoscopy, and on the endoscopy, as I said, this is the next step to investigate persistent symptoms. And by performing endoscopy, it should be done by the PPI holiday, because when you stop the PPI and then you do the endoscopy, it increases the yield for identifying erosive esophagitis, and it determines whether an alternative diagnosis like eosinophilic esophagitis is responsible. In patients with persistent GERD symptoms on PPI, there is low likelihood of finding reflux esophagitis, so PPIs should be stopped before doing the endoscopies. Next, please. And we all know the LA classification, grade A, B, C, D, depending upon the ulcers length and the number and extent. Next, please. Next, please. Well, you did the endoscopy, and in an endoscopy, you couldn't get any clue. So, what to do next? Next is the reflex monitoring. So, next, please. With negative endoscopy, to establish the diagnosis of refractory GERD symptoms, whether this is really because of the reflux, you go for the reflex monitoring. You monitor the number of reflex and the symptoms of reflex. Therefore, in reflex monitoring, what we do, we record four parameters, variables. One is the number of reflex and observational period, that is 24 hours. And second, the episodes of the symptoms. And it's not necessarily that the patient heartburn is correlating with the number of reflux. So you have the four the reflux with symptoms and reflux without symptoms, symptoms with reflux and symptoms without reflux, and then you take the reflux parameters and its scoring and all those things. I won't go into the detail of that, but point is, as I said, what makes the GERD into refractory, there were two main things. One is the persistent abnormal acid reflux, and second is reflux hypersensitivity. So when you suspect it may be abnormal acid reflux, you do the reflex pH monitoring by off PPI therapy. You make the patient off of the PPI for 7 days, and then you do the reflex monitoring, and it tells you whether the patient has got abnormal acid reflux. But if you suspect this is the reflux hypersensitivity, you do the pH monitoring by on PPI. The patient remains on the PPI and you check that. And even if your reflex monitoring is not working, what you do, you go for the esophageal manometry. Next, please. The HRM, it should be performed. This is the very, very important if you are planning that I am sending my patient for anti-reflux procedures, because this is important to evaluate for the achalasia, and this is very, very important, the reflex manometry, to tailor the anti-reflux operation. For example, if there is normal peristalsis, then the patient is a candidate for Nissen or complete fundoplication. But if there is ineffective esophageal motility on HRM, then the partial fundoplication should be plain. The Nissan fundoplication will not be helping in that case. And if there is absent contractility, no peristaltic activity in esophagus, it is simply a contraindication for the fundoplication. So this is mandatory to go for the manometry and then plan accordingly. So now on the right side is the when my lifestyle modification has failed, pharmacological therapies failed, I'm sure this is my refractory GERD. What are the options? The most important and the most given practice option is the fundoplication, and it may be done by open surgery, by laparoscopic surgery, and by the endoscopically. Next, please. Next, please. Yeah. By the fundoplication, depending upon the rape, it may be 180, it may be 270, it may be 360. 180 degree is called anterior rape or the Watson rape. 270 degrees called the posterior rape or the Toupet rape, and the 360 or around rape is the Nissen rape, and this is the most commonly practiced surgical procedure. As I said, it can be done, fundoplication can be done through open surgery, but now this is the laparoscopic anti-reflux surgery, the fundoplication, this is the treatment of choice across the world, and this is done. And now the people are trying to go for the endoscopic, that is the trans-endoscopic incisionless fundoscopy, where the scope is passed and it has got a device there, and then through the endoscopic device, the stomach is raped around and it is sutured around, and the fundoplication is done. Next, please. In addition to the fundoplication, that is a surgical operation, now there's another option available and being practiced, not universal one, but this is an option, and no people are opting for it. That is the magnetic sphincter augmentation. And what's that? Next, please. The MSA or magnetic sphincter augmentation, it is done by the Linux reflux management system. What is that? It's a necklace of titanium beads with magnetic cores, and it encircles the distal esophagus to some sorts of block the lower esophageal sphincter and prevent the reflux. It's as compared to the endoscopy, the fundoplication, it's less invasive and more readily reversible than the fundoplication. So when you want to reverse, you just remove the bead, तस्बी जो है वो आप हटा लेते हैं, and then it goes to the back. Next, please. And this is the way how it is done in the three the pictures, that how it is applied around the lower esophageal, the gastroesophageal sphincter. Next, please. This is important. That how it works. The above is the normal peristaltic pressure in the esophagus, that is the 35 to 80 millimeter of mercury. It's the normal pressure. In the stomach, the pressure is 5 to 10, and this system gives pressure of 15 to 25. So the peristaltic activity, peristaltic wave, it propels the food from the esophagus into the stomach, but from the stomach it cannot come up because the pressure is more. The stomach maximum pressure is 10, and it gives you 15 to 25 millimeter of mercury pressure. So by this way, it hinders or it blocks the refluxate from the stomach into the esophagus. Next, please. So the MSA is a safe and effective alternative to laparoscopic fundoplication. The clinical outcomes of the T procedures are similar. The minimal surgical dissection required for MSA results in greater technical ease, shorter operative time, and shorter duration of hospital stays than for fundoplication. MSA is also easier to reverse, and MSA may result in less gaze bloating and greater ability to belch and vomit than fundoplication, because it's the sorts of the not fixed one, dynamic one. The magnetic resonance imaging restriction is one of the side effects of this. These patients cannot undergo the MRI examinations, and of course there is not huge data on the long-term safety of the MSA outcomes. Next, please. May I have the last option, in addition to the fundoplication and magnetic sphincter augmentation, is the radiofrequency anti-reflux treatment. Next, please. Next, please. Yeah, this is when the lower esophageal the gastroesophageal junction, the radiofrequency is applied, and it's a sort of inflammation happens, and then it's some sort of scarring, and it closes or narrows down the GE junction. Next, please. Next, please. This is the device is called Strata, and the standard endoscopy is performed in the distance from the incisors to the squamocolumnar junction, that is Z line is measured, then endoscope is removed, and the RF catheter is passed transorally and positioned 2 centimeter above the Z line, which was measured. Next, please. Next, please. Then the 4 needle electrodes, it is deployed to present the length of the 5.5 millimeter, and the radio frequency delivery is commenced for 90 seconds, and then the device is rotated, and in total 56 lesions, almost they are made in a period of 30 to 35 minutes, and later on these sites they develop sorts of scarring, and the GE junction it is narrowed down. Next, please. Because data on the efficacy of this method as anti-reflux procedure is inconsistent and highly variable, so therefore we cannot recommend, I mean the authorities cannot recommend this use as an alternative to medical or surgical anti-reflux therapies, but in future probably this will be the option. So to conclude my talk, to understand what are our options, and to say what is what is refractory GERD, why the GERD becomes refractory, how to proceed, we must be knowing all something basic knowledge about the GERD, what is GERD, why it is normal reflux is converted into GERD, when to suspect, how to go about, and how to treat. Next, please. And in the treatment, the life modification and pharmacological therapy, of course, they are the mainstay. But if my patient is not responding to these, then my options will become the fundoplication, the magnetic sphincter augmentation, and radiofrequency anti-reflux treatment. The fundoplication is the gold standard, the laparoscopic, but now the people are going for the endoscopic fundoplication as well. And probably in the future, this may be the option, the easy option, or even the magnetic sphincter augmentation has been tried. Next, please. So, my dear colleagues, I based my talk on the ACG clinical guidelines for the diagnosis and management of GERD, and which appeared just on the 22nd November of 2021, so around less than 2 months ago. So, I'll suggest that you all should refer to these guidelines, and because they are very comprehensive and very practical, and there are so many, troubleshooting answers in these as well. So thank you very much once again, the organizers, and sorry for that clinical hitch which happened, but I'm sure that I was able to communicate my message to all of you. Thank you very much.
Thank you, Professor Dr. Javed Farooqi Saab, for such a excellent and knowledgeable talk. Our next speaker is Professor Dr. Altaf Alam Saab. He is Professor of Gastroenterology and Hepatology, Sheikh Zayed Hospital, Lahore, and currently he is working as consultant gastroenterologist and hepatologist at Evercare Hospital, Lahore. And he will be talking about what's new in hepatitis B and D. Professor Saab.
Thank you very much, Dr. Hamid. I'll try and share my screen, and if I'm unsuccessful, I'll ask you to share my slides from there.
Sure, sir.
No, I'm not successful as well. So if you could display my slides, and I'll speak from here.
Sure, sir. Sir, be right back to it. Thank you. Sir, wait for a while. We are uploading it.
Okay, thank you. I did pass on the message to Maria to keep my slides ready.
Sir, it's ready. But just it's in process. It's loading. It will take 10 to 15 seconds more, sir. Sir, it's ready.
Can you see my slides?
Yes, we can see it, sir.
I can't see. Now I can see it.
Ah,
Okay. Okay.
right, sir.
Thank you very much, Dr. Hamid, for your kind
Well,
introduction and for the organizers to giving me this opportunity to talk about what's new in hepatitis B and D. Conference. Next, please. I bring greetings from my hometown, Lahore, and I have no disclosures to make regarding this presentation. Next, going to talk about new indications to start treatment for chronic HBV, new indications to stop nukes in e antigen negative non-serotic HBV, tenofovir alafenamide or TAF as we call it, for use in pregnancy to prevent mother to child transmission of HBV, and touch upon future treatments for HBV and HDV. Next, please. So firstly, new indication to start treatment for chronic HBV. Next, please. Well, as we all know, the first three indications have been in vogue for many, many years. So a patient with HBV DNA more than 20,000, ALT more than twice upper limit of normal, whether e antigen positive or negative, should start treatment regardless of the known fact for many years. A patient e antigen negative or positive with DNA of more than 20,000, ALT of more than upper limit of normal, and or at least moderate liver necroinflammation or fibrosis. What we mean by moderate liver necroinflammation or fibrosis, this is A2 or any level more than F1. So this is what we mean by significant inflammation and fibrosis. And any patient with cirrhosis or decompensated with a detectable HBV level and regardless of ALT level should be treated. Now these three indications are being followed for many years. EASL 3 years ago introduced two new guidelines for starting treatment in chronic hepatitis B. The first one in what we call hepatitis E antigen positive chronic infection or immune in those most old, normal ALT, very high HBV DNA levels, and if they may be treated regardless of the severity of liver histological lesions, either on liver biopsy or on non-invasive methods like FibroScan. So been debating a long time that all should be. EASL guidelines has at least partially accepted our demands by asking us to start treatment, that we may start treatment in immune tolerant patients who are more than 30 years old. The other indication that has been added in the EASL guidelines is those patients who are e antigen positive and or negative, but do not meet the treatment criteria of viral and of more than upper limit of or more than twice upper limit of normal, but or cirrhosis, or manifestations. Such patients, despite not meeting the these two, the new chronic hepatitis B, and this is next, please. Now, new indications to stop Nukes antigen non-serotic HBV. Next, please. We have that nucleotide and nucleoside analogs may be stopped in selected, and I will repeat, in selected group of non-e antigen negative patients who have achieved long-term virological suppression, which is more than 3 years of virological suppression under nucleotide or nucleoside analogs, may be considered for stopping therapy, provided close monitoring after stopping therapy. I must emphasize that such patients are rare in our. One, they will not come back for follow-up and may have severe flares and even die from the flare-up of chronic hepatitis B. So one has to be very mindful of these facts. And for all practical purposes, I would emphasize my colleagues that most of these patients forever, as we have known for many years. But if more patient, you make that he can meet the requirement of close after stopping therapy. Next, please. And here I present presented in ASLD last year, just a couple of months back. Of course, there is a lot of that technique works if you can select your patients properly, follow them up properly. Retrospective cohort study called Retract B, where nucleotide analogs were stopped in patients with chronic hepatitis B, antigen negative patients, and they were followed up for up to 4 years. About 1,000 patients, and the primary outcome was sustained remission 1 year after nucleotide analog cessation. Majority of patients were male and Asian. Genotype B was the predominant. Various therapies, predominantly entecavir. Median duration of therapy was 3 years. E antigen negative at start were 84%. Mean surface antigen quantitative at the time of cessation was 2.6 log, not international units, but 2.6 log international units per mil, which means around 1,000. Next, please. As you can see from the out, 44% of patients had sustained remission or surface antigen loss, whereas 40% of patients had sustained remission with antigen loss. But if you follow them up to 4 years, respectively. What do we get out of this study? Only 30% had sustained remission. 10% of patients only had surface antigen after 4 years, and only 20% had sustained without surface antigen loss at 4 years. So the numbers are rather small, but still, 1/3 of patients were able to stop therapy successfully forever. So worth trying, but only in select group of patients motivated for close follow-up. Next, please. Sustained remission loss at 4 years. One, antigen positivity in the beginning, low surface antigen, relapse after stopping therapy for 1 year. So these were the predictors of sustained remission. Next, please. This just tells you that a lot of patients, 40 to 65%, had either virological, biochemical, or clinical relapse, and retreatment was needed in 1/3 of patients. So we were successful in keeping off treatment around 65% of patients who were stopped therapy. So as I said, worth trying. Next. Keeping this in mind, various societies have included quantitative surface antigen and a new marker, hepatitis B core-related antigen, as a guideline or a predictor of successful cessation of therapy in. So low quantitative surface antigen and low hepatitis B core-related antigen at the time of cessation is associated with long-term remission and even if you stop years of treatment and also viral suppression. Next, please. APASL has also now added this last year in its guidelines that quantitative surface antigen may serve as a guide in patients who have been on nucleotide therapy. And as it appears here, surface antigen level quantitative less than 100, therapy with close monitoring. In others, there are other, which is not topic of discussion today, so I will not. Next, please. So what we get out of this study is sustained remission and surface antigen loss were uncommon after stopping NA therapy, even in well-suppressed patients, with 66% patients experiencing virological relapse by year 4. No relapse within the first year of treatment discontinuation, white race, E antigen positivity at the start of treatment, and low surface antigen, and I would add low hepatitis B core-related antigen is related with sustained response. Next, please. Now, a provocative study for the first time, presented in ASLD last year, tenofovir alafenamide for use in pregnancy to prevent mother and child transmission of HPV, or in pregnancy at large. Next, please. Here, around 200 patients at stage, newly diagnosed chronic hepatitis B or previously diagnosed chronic hepatitis B on treatment always do either with TAF, pregnancy, to TAF or TDF. All these patients were included. The primary endpoints were maternal safety, infant safety, and infant growth parameters at and 7 months. Secondary endpoints was undetectable HBV DNA and ALT normalization in mother, and HBV serological markers in the infant at 7 months. Next, please. What we see here is that both TAF and TDF were equally well tolerated in terms of minor side effects, and also matched very well in terms of pregnancy. Next, please. In terms of delivery by cesarean section after birth, and some adverse events, both drugs make them equally effective so far. Next, please. Forget about this busy slide. Just understand that it tells us no significant differences observed between any anthropo received versus both parameters PDF or. Next, please. In terms of efficacy, perinatal agent for preventing mother to child transmission, and works very well, as good as any other medicine. 9% and 100%. Good it was. Equal and as good as one would expect with such treatments. Almost 100% had been at postpartum and month 18. ALT normalization 5 to 100%. Normally from these treatments, 20 to 20 as well. Efficacious and next, please. From this study, there was mission in either TAF or TDF group at 7 months. Of course, all infants received HBV immunoprophylaxis with HBIG and HBV vaccine like we normally do. TAF and TDF group had similar efficacy and safety outcomes between baseline and postpartum month 18. So TAF, or tenofovir LF, which is not yet categorized or considered safe to be used in pregnancy by all the regulatory authorities in FDA, may play a role in pregnant women with chronic hepatitis B, and also for preventing mother-to-child transmission in the future if these data are replicated in larger studies. Next, please. So what about the future treatments for HBV? Next, please. To understand this, we must know that with therapies, we are only achieving partial cure. That is, we are suppressing HBV DNA, but HBsAg remains positive. If we aim for functional, complete, and sterilizing cure, which means antigen should become negative, anti-HBs should appear, and cccDNA should disappear. This is not yet. So to cure, complete cure, cure. Next, please. I will not go into the details. There are bits which are being attempted to get rid of this virus better than what we are doing today. And there are more than 50 drugs in various phases of drug development, but only 25 drugs are beyond phase 1. So some progress is being made in this area to achieve functional cure, sterilizing cure, and complete cure. Next, please. What are these therapies? HBV core inhibitors, Salih nucleic acid polymers, various I won't go into the details because they are only in phase 1, many years from being into the market. Leave it. Next, please. What strategies are being followed to achieve functional cure? We are working on 3 lines. One is to inhibit viral replication with various newer agents, reduce viral antigen burden, and boost immune responses with all these newer agents. And I hope that in future, drugs, either alone or in combination, work better than what we are doing so far. Next, please. Third strategy that has been attempted and has been successful is using PEG interferon to inhibit therapy. Various strategies have been used. De novo combined PEG interferon and nucleotide analogs, which is not beyond single agent. Interferon treated switch or add-on nucleotide analogs. Analog treated with switch to PEG interferon. Treated. So some of these studies, which are already published, have shown that you can achieve better results than either agent alone or de novo combinations with surface antigen loss of up to 14%. So this is one strategy. And as I showed, that APASL guidelines has now included that if surface antigen remains higher after 3 years of therapy, you can try PEG interferon adding or switch on therapy to see what response we get. Next, please. And finally, I will talk about the future HDV. Next, please. Well, there are various agents to target this difficult to inhibitor, bulevirtide, prenylation inhibitors, lonafarnib, and a few other drugs like nucleic acid polymers have, but there is nothing positive. These bulevirtide, and I'm only going to talk about this agent as a newer therapy for prenylation inhibitor. Lonafarnib has not progressed. A phase 3 trial is in progress, and we don't have the data to share with you. So we will not talk about these two anymore. Next, please. Again, a study presented in ASLD last year, just a couple of months back, where bulevirtide with or without PEG interferon was used for chronic HDV infection as a compassionate authorization plan. It's not approved yet, but it has been submitted for approval, but compassionate authorization for use was used, and they treated about 150 patients with either bulevirtide 2 milligram subcutaneous once daily for more than 12 months, or bulevirtide 2 milligram subcutaneous once daily in combination with PEG interferon for more than 12 months. The endpoints were, of course, HDV RNA undetectability or decrease by 2 log from baseline. And the response is ALT normalization. Next, please. As you can see, HDV RNA undetectability or decrease by 2 log from baseline at 12 months was seen not only in high proportion of combination therapy, also in bulevirtide 2 milligram subcutaneous alone therapy as well. So around 70% versus 93%. So very good response, something we can look forward to in the future as a newer treatment available to us. Next, please. In terms of ALT normalization, about 1/3 to half of the patient at 12 months, either on single agent or combined therapy, achieved that. Next, please. Adverse events were, of course, more common with PEG interferon meters were fairly well matched. Next, please. So, what is the take-home point from this study presented in ASLD? Bulevirtide with or without PEG interferon is safe and HDV virus suppression. Virological suppression is more common in combination arm than in single agent. Next, please. And I present here the MIR 301 study with high or low dose bulevirtide in patients with chronic HDV infection. And this was also presented in ASLD last year, where bulevirtide 10 milligram versus 2 milligram was compared in patients with chronic delta infection. And the endpoint was undetectable HDV RNA or decrease by more than 2 log, same as in the previous study. Next. As you can see in this study, they also did liver biopsies and checked intrahepatic HD antigen. You can see the numbers were better for both bulevirtide 2 milligram or 10 milligram arms as compared to no treatment arm. Next, please. So the take-home points from this study is that intrahepatic HDV RNA levels significantly declined by week 48 with bulevirtide treatment versus none. More than 33% of bulevirtide treated patients achieved undetectable HDV RNA, which is very good. From a simple therapy, non-interferon, we are achieving same results that we were achieving or better results that we were achieving with peg interferon. Next, please. So here recently in ASLD, in a PSSLD meeting, Mario Risotto proposed this for future treatment of HDV in patients who are non-serotic and suffering from chronic delta infection. If there is no contraindication to interferon, use combination bulevirtide 2 milligram plus interferon for 48 weeks. But if they have interferon, use bulevirtide 2 milligram, but this has to be used long term. In compensation, we can use interferon, then bulevirtide and interferon combination should be used at least for 48 weeks. But if mono in decompensation, unfortunately, we don't have any answers yet. Of course, interferon is not in such patients. Whether bulevirtide alone long term may be used, we have answer. We'll wait for that, but certainly these are the categories of patients which can be treated either with single agent or double agent, and the results are better than what we were achieving with interferon alone. Next, please. This brings me to my talk. Thank you very much for thanks organizers for inviting me, and I'll be happy to take questions at the end. Thank you very much.
Thank you, Professor Dr. Altaf Alam Saab, for such a wonderful and informative talk. Now we have a session for question and answers, and from all the speakers. Any question from the audience? There is a question for Dr. Mohammad Salih Saab, and how long it takes to normalize LFTs in patients with drug-induced liver injury, and treatment recommended for it.
Thank you. Can you hear me?
Yes, sir.
Okay. Now, it takes into account that which enzyme has been raised with the drug, one. Second, it takes into account that what sort of drugs were you using, and what's the half-life of that drug. So in all these things, like we said that the mitochondrial AST has got up to 87 hours of half-life. So you think of that. If it is only bilirubin is a bit high, then you also see it like that. Or if it's an ALT, it's around 47 hours or so. But it also needs takes into account that what is the half-life of the drug is, and the offending drugs has been whether you have removed it in time or not. So there is no specific treatment for that, but if an antidote for other reason is required, then one may can think of that. But normally you just take off the offending agents and that's it. Some of the times, if it is an acute liver failure due to any reason, one may be thinking of using N-acetylcysteine, be it a liver injury related drugs or otherwise. So no such things are available for that. If you take like the alcohol as a drug, then yes, we should be using steroids if your Madri score is more than 32 or if the MELD score is high. So I hope I have answered it.
Thank you, sir. Acha, we have a question from Dr. Professor Javed Farooqi Saab. Do GERD patients need surveillance for Barrett's, and how frequently after diagnosis of GERD?
Yeah, thank you very much. Very good question. Though the Barrett is not that common in our setup as it's in the Western, but yes, if the patient has got one is that if the patient has got the long segment Barrett, then of course the surveillance is warranted, and depending upon the biopsy whether this is the metaplasia, dysplasia, and anaplasia. One is all that thing. Second is this is the refractory or the long-standing GERD, and especially when the patients, the age, and if there is a family history of the adenocarcinomas of the esophagus, though this is squamous is the esophageal carcinoma. So in that subgroup, yes. But one thing is that what we have seen that even, but maybe Professor Altaf Sahab and Salih Sahab will second me that probably we can even recall by fingers how many of our patients developed the Barrett and the Barrett carcinoma. So this is what we come across when the patient presents with the esophageal carcinoma. We take the biopsy and then it comes out that yes, this was the Barrett and carcinoma. So, but as per se, that in each and every GERD patient, probably it will not be that cost effective to go for the endoscopies. But yes, if there is a high risk, you go for.
Thank you, Professor Javed Farooqi Saab. Sir, we have a question from audience for Professor Dr. Altaf Alam Saab. Can we use tenofovir alfenamide and decompensated HBV CLD patients? Is it recommended?
Thank you. Very nice question. It is certainly not recommended yet to be used because the data is not available. I'm not saying that it will not be effective, as I've shown today, that it has been tried in pregnancy and works well. So I'm sure it will work well, but there is no data. So it is not approved for use yet in decompensated cirrhosis. Thank you.
Thank you, sir. Thank you. Any other question from audience? So I would like to conclude the session. We are thankful to our guest speakers, Dr. Mohammad Saleh Saab, Professor Dr. Javed Farooqi Saab, and Professor Dr. Altaf Alam Saab, on the behalf of ICON 2022 and Gastroenterology and Hepatology Department of Indus Hospital, Karachi. And we look forward in future for such collaboration with us in the research and academics of such senior persons. Thank you, sir. Thank you. We had a
Thank you,
wonderful
Dr.
session.
Naidoo.
Thank you.
Thank you.
Thank you, sir.
Assalamu alaikum.
Thank you, sir.
Assalamu alaikum.
Walaikum salam.